Hello, and welcome to the first virtual lecture for cardiopulm rehabilitation. This first lecture is going to be an overview of some breathing biomechanics. And I put this first to make sure it's in your heads for the rest of the semester and to encourage us to think about the three-dimensional structure of our core and how our thoracic cavity and our abdominal cavity are interwoven and an integral part of human stability and human movement. So if we just look at the bones of the skeleton and ask the question, what holds the skeleton up? How do we maintain the structural support of our bones? Why does the skeleton stand up? I would guess a lot of you, the word that might have jumped into your mind is, we have muscles, lady, duh. But sure, we have muscles, but if you look at those bones, and I like to do this in class with like a skeleton in front of you, I mean, the origin and the insertion, like, how does it actually hold it up? Why doesn't our skeleton collapse on itself? What allows us to hold the body upright? I would argue that we cannot stabilize our skeleton with only our external muscles, or we would crumple like you see in the picture. The key element to the effectiveness of our external muscles is our core strength. Core strength is absolutely critical to maintain appropriate pressures within our thoracic cavity as well as our abdominal cavity. Because proximal stability is necessary for distal muscle force production. For our external muscles to functionally hold our skeleton and move our skeleton, we need to have core strength. So how many of you have, and this would work much better if I could see a show of hands. In my head, I'm imagining your smiling, eager faces in 356. How many of you have had the opportunity to do a pre and post evaluation when someone goes in for some kind of abdominal surgery, something in their thoracic cage? Have you guys seen this? You see a person one day, you do a pre-op evaluation, 1 or 2 days later, you see them after a surgery, and is there a difference in their functional strength? Unbelievable. They're so weak, right? They're having a hard time getting out of bed. They're having a hard time using their extremities appropriately. Did they lose strength in the 1 to 2 days since their surgery? No, absolutely not. Incisions and pain have impaired their ability to maintain central pressures. And they look so weak. And you've probably talked in other classes, we'll talk in this class about stabilizing incisions, stabilizing the chest when there's chest tubes to limit that pain, strategies to create central pressure, and then pop, they can get up out of bed, they can do their sit to stand, their functional strength returns when they have the ability to maintain central pressures. Mary Massery came up with the idea of the soda can model of core stability. And it works really well for me to keep my head wrapped around what we're talking about, because sometimes it can feel a little abstract when you're saying core strength and intra-abdominal pressures. What are we talking about? But if you picture a can of soda, maybe bubbly water is better nowadays because I don't know if people drink soda as much as they used to, but Maybe this could be the bubbly water can model of core stability. If you picture a fully not even opened can of soda, what is the can of soda made out of? What is the structure that it's made out of? Very weak aluminum, right? Just very thin-walled aluminum. When it is full and it is closed, can you crush this can? I would argue I could stand with my full body weight on a can of soda if it's never been filled. If it's not going to bend, it's not going to break, I'm not going to crush it. And why is that? It's because this can is pressurized, right? Inside of this can, there is pressure exerting an outward force, stabilizing the weak exterior. What if the same scenario I gave you at the beginning, the soda can, is open and you emptied out the contents inside? So now it's an empty can and there's no pressure. Can you crush an empty can? Of course, we've done it 1,000 times. Hopefully you haven't crushed it on your head recently because it's not recommended. But you can absolutely crush an empty can. What is the difference? Without the central pressure being generated, pushing outward on those thin walls, the walls of the can lose their structural integrity and they're easily overcome by external force. In the human body, the primary source of our central pressure generation is the diaphragm. Yes, obviously the diaphragm you guys are familiar with. It is our primary muscle of inspiration. But I challenge you to think of the diaphragm beyond just a quote-unquote breathing muscle. The diaphragm is critical to our core stability. It goes right in the middle of the can, and it helps to regulate and adjust central pressures. The diaphragm has the capacity to be both a breathing muscle and a muscle of postural support at the exact same time. It can do both jobs simultaneously. So its location in our central cavity separates our ventral body into two distinct spaces. We have the thoracic cavity and the abdominal cavity, and the diaphragm is dividing between them. And you guys know the diaphragm is a dome that can descend or elevate. That's the action of the diaphragm. When the diaphragm descends, when it flattens and moves downward, it decreases the thoracic pressure because it creates an increased volume in the thoracic cavity. And as you increase volume, you decrease pressure. This should be the obvious part. Maybe all of this is obvious, but this is the obvious part. That's how we suck our air in. That's inspiration, right? The descent of the diaphragm increases the volume of the thoracic cavity, creating a negative pressure to pull it in. At the same time, if the diaphragm is descending and increasing the volume of the thoracic cavity, it's obviously reducing the size of the abdominal cavity and actually raising the intra-abdominal pressure. So the movement of the diaphragm has a lot of control in the pressure generations in the thoracic and the abdominal cavity. But if you're thinking about the soda can model, right, the pressurized can of soda that would not crush if I stood on it when it was full and sealed was contained on all sides, right? So what I just told you is if the diaphragm descends, it can raise the pressure in the abdominal cavity. Is that absolutely true? Not without a floor. If you descend the diaphragm and there's nothing holding on down at the bottom, Well, you can just pooch out this way and there will be no increase in intra-abdominal pressure. The only way we see this effectively raising intra-abdominal pressure is if there is a floor on our pelvis, on our abdominal cavity. We call that, obviously, the pelvic floor. The pelvic floor holds the can closed at the bottom. So when the diaphragm descends, with an intact pelvic floor, you can raise intra-abdominal pressure, which the picture has already given away the answer, but of course we have to have an external valve on the top as well. We close the bottom of our can with the pelvic floor, and we close the top of our can with our vocal folds. We have a pressurized can, and we can control those pressures by opening or closing our vocal folds, by contracting and activating our pelvic floor, and by activating and moving our diaphragm. I want you guys to feel this right now. So what I'm going to have you do is close your vocal folds, so close your glottis, kind of hold your breath, and attempt to bear down, like push into your pelvic floor. So with your vocal folds closed, your glottis closed, bear down. Can you feel the pressure in your pelvic floor? Hopefully the answer is yes. Try the exact same thing, except this time have an open glottis. So an open, do that while trying to bear down on your pelvic floor. Go ahead, try it. Just because it's a video, it doesn't mean you're not supposed to do it. Could you feel the difference? If you opened your soda can at the top, you have released that pressure, and it becomes very challenging to generate enough positive pressure to bear down into the pelvic floor. You depressurized your soda can, and you decreased your ability to create the necessary core pressures needed to stabilize from within. And we'll see this relate to many different issues that will tie in by the end of this lecture, and then hopefully we'll weave it throughout the course. But this is related to GI issues. We see when individuals have abnormalities in diaphragm strength or inability to close their glottis. If they can't generate enough pressure, it's going to influence their ability to move their GI system, and this can lead to severe constipation when you can't generate abdominal pressures to push feces out appropriately. Okay, so the diaphragm has divided our central cavity into the thoracic and abdominal pressures. Then that means we actually have differential control of those pressures. So let's first talk about the pressure in the abdominal cavity, or the intra-abdominal pressure. This in our central cavity is the high pressure system when you compare it to the thoracic cavity, or even if you compare it to atmosphere. If you are laying supine and at rest, a healthy adult would have about 5 to 7 centimeters of water pressure in their abdominal cavity. If you look at the next example in your notes, an obese individual in the exact same position would have about 9 to 14 centimeters of water pressure. There's a lot more weight bearing down on the abdominal cavity. Look at those numbers for a second. Healthy adult, 5 to 7 centimeters of water. Obese individuals, 9 to 14 centimeters of water. That's double the intra-abdominal pressure of their age-matched controls. That means you're going to need twice the strength in all the areas that support that pressure, or pressure will escape. So higher intra-abdominal pressures have to be supported with muscular activation. If pressure is escaping, we see some common problems that are frequently occurring in individuals who are overweight. GERD becomes very common, extra abdominal pressure forcing the acidic contents of your stomach upward, pressure is escaping. Pelvic floor prolapse. The pelvic floor can't support all that pressure, and you see prolapse and abnormalities in pelvic floor function. Frequent hernias, pressure escaping out of the abdominal cavity. The intra-abdominal pressure is very dependent on positioning and activity. So when you go upright, your intra-abdominal pressures triple, and now these numbers are all in healthy weight individuals. During motor tasks, you can see this going up even more as you go to heavier and heavier weights of lifting, squatting. Obviously, jumping is going to be one of the highest levels of intra-abdominal pressure. Intrathoracic pressure is the pressure generated in our thoracic cavity, and this is the low pressure system, and it's always going to be lower than abdominal pressure. The next part of your notes is just normal breathing, right? During normal breathing, you need to have pressure in your intrathoracic space that is lower than atmosphere in order to create that negative vacuum to suck air into your lungs. And then to exhale, we have to generate pressures in our intrathoracic cavity that are higher than atmosphere. Once you get intrathoracic pressures at 3 centimeters of water or higher, you're going to start to have exhalation. You will exceed the pressure from the outside. This concept of intrathoracic pressure is going to come up again and again in this class. We will talk a lot in this class about coughing because the ability to generate very high flow rates is critical for the health of our lungs, the clearance of items that might have gotten into our lungs, prevention of pneumonia. Being able to cough effectively is a big, big deal. And when people can't clear effectively, they had much higher risks of pulmonary infections that can ultimately lead to death in some populations. So the ability to generate high thoracic pressures allows you to do really high flow rates on exhalation. How do we dramatically increase intrathoracic pressure? Well, close your glottis. You got an external valve here at the top. If you pinch off your glottis and kick your abdominals in, you have a pressurized can and you're driving your muscular effort to add pressure to the thoracic cavity. So you can increase intrathoracic pressures when you close your glottis. You've seen the effects of this when you hold it, and then suddenly open it. That's a cough. You use a closed glottis to yell. You can get much higher volumes of your voice if you restrict your vocal folds and allow a greater amount of pressure. Oh, we had this fantastic lab experience that I wished I had recorded. I'm sure you guys have met Ken at this point. He is a tetraplegic and he would come in for labs and he doesn't have any activation of his abdominal muscles. So very poor ability to activate abdominals to help assist in pressure generation. So he is going through the lab, and as the lab is going on and he's getting more fatigued, and we had him take off his abdominal binder. If you're not familiar with that yet, you will learn about it in this class and neuro, but it basically squeezes you from the outside to help create some intra-abdominal pressure. He had his binder off. And the thing that was so cool in lab was all the students were on rolling stools, and they slowly started getting closer and closer and closer to Ken. And they were all leaning way far in because the volume of his voice was going down, and they could hardly hear him because he was getting fatigued and he didn't have his binder on to generate the necessary positive pressures to push his voice out in a loud way through his vocal folds. It was visually watching the students just like zoom in on him because they couldn't hear was like this physical representation of the loss of his positive pressure generation that you could see happening. So we utilize this functionally. This is a huge area of speech therapy, which is outside of a lot of what we do, although there's tons of overlap, especially for you peds people. But these ability to generate pressure is a key element to function and functional movements, and being able to coordinate these two cavities effectively will become critical when we're treating patients in the cardiopulm world. So if there is anything going on in the patient's musculoskeletal world that is compromising their ability to maintain these central pressures, perhaps they have a tracheostomy, so they can't close their glottis. Perhaps they have pelvic floor disruption and they can't stabilize from the bottom. Abdominal muscle weakness or paralysis, diaphragmatic weakness or paralysis. If anything is compromising their abilities to maintain these central pressures, it is going to compromise their ability to stabilize their core. If we don't have central pressure generation, we can't keep that proper alignment. We can't maintain proximal stability. And proximal stability is necessary for distal mobility. You can see the difference between these kiddos in the pressure generated in the central cavities, allowing, almost like a balloon inside of them, holding them up, stabilizing the spine, and allowing the freedom of the movement of the distal extremities. Reduced ability to maintain your central pressures crushes your can and leads to things we see all the time: poor posture, poor movement strategies, abnormal muscular use and activation patterns, these long-term compensations for a poor core stability. I hope as we go through the semester, we'll keep bringing it back to this, but this image of this pressurized can creating this column of support and stability that gives us the necessary support for all of human movement is absolutely critical. So let's talk about some of the muscles of ventilation that are key here. So our inspiratory muscles are seen on the left, expiratory muscles seen on the right. Our primary muscle of inspiration is, of course, the diaphragm. The external intercostals help and assist in inhalation. And scalenes are actually active during most inhalation, but they're not considered a primary mover. Exhalation at rest in a healthy population should be passive. The recoil of that diaphragm, the elastic recoil of the lungs, should create enough positive intrathoracic pressure to move air out, but we can kick in internal intercostals, and then the abdominals are a huge muscle for that. But let's really zero in and focus on this diaphragm, this central pressure generator, and also the primary muscle of inspiration. The diaphragm is a very thin, dome-like skeletal muscle, and it really is thin. There are sections that are like 2 to 4 millimeters in thickness. Very, very thin, delicate muscle. It can be divided and described in sections, where the costal sections of the diaphragm attach to the ribs 8 to 12, where the sternal portion attaches to the posterior wall of the xiphoid, and the crural is anchored to those vertebral bodies. So the two domes of the diaphragm come together at the central tendon, right? You can see as in white here. But the central tendon is sitting right here, and it's actually what holds and supports the pericardial sac, where the two domes on either side is what supports the lung tissue. It's great to look at, and I like this view here on the left, where you're looking up into the dome, and you can see these big things that go right through the diaphragm, right? Like we've got this vena cava that goes right through the central tendon, which helps explain why the diaphragm has a role in enhancing venous return. It squeezes right around this big vena cava. The esophagus goes right through the diaphragm, where the diaphragm helps to support the separation of the stomach from the esophagus. In fact, abnormalities in diaphragm activation are highly associated with GERD because of this interrelationship between the esophagus and the diaphragm. There are these aponeurotic arches that actually physically connect the diaphragm to the quadratus lumborum and the psoas major, running right up along it. It is fascinating the degree of intermingling that goes on at this place in our body and the way in which the overlap of structure and function is seen, and you will see it in your practice over and over again. All right, let's go back to the basics and just the action of the diaphragm in terms of breathing. So we've got this dome-like shape that sits below the lungs on top of the abdomen. And when we take an inhalation, the dome descends and flattens. Seen here, by flattening out, you increase the vertical diameter of the lungs. By increasing the vertical diameter of the lungs, you've increased the volume, which drops the pressure to allow air to get sucked in. When we're talking about the anatomy, and in lab, we're going to have an opportunity of actually drawing the heart and lungs as surface anatomy, because it is hard to remember exactly where things are, strangely. But with a full inhalation, when you really take a big breath in, the lungs can drop all the way down to about the 12th rib posteriorly. So we can get a big increase in vertical diameter of the lungs. Well, what's going to happen down here if we just dropped the diaphragm? It is going to reduce the vertical diameter of the abdomen, which would decrease the size of the abdomen. If you're decreasing the volume, what's going to happen to the pressure? We're going to see a rise in intra-abdominal pressure. Now you might be saying to yourself, why? Can you guarantee that? Well, I can't guarantee that it works, but it should work if you have a proper activation of your pelvic floor. And EMG studies have shown that we see activation of the pelvic floor just prior to inhalation. So we kick our pelvic floor on just a second before we start to inhale to lock the floor of our soda can closed, so that when the dome descends and we shrink the size of the abdominal cavity, we are able to generate increased intra-abdominal pressures, because the elevation in intra-abdominal pressures actually helps to push the ribs out laterally. So the ribs get pushed out laterally because we're able to generate the positive pressure for the diaphragm to work against. As the diaphragm descends and we have an intact abdominal wall, an intact pelvic floor, as it pushes down, it has nowhere to go, so the ribs get pulled out and away. This motion is known as the bucket handle motion, because the ribs start where the bucket handle is down, and as the diaphragm descends, if there's an intact abdominal wall and an intact pelvic floor, the pressure being generated from that descent of the diaphragm kicks the ribs up and out in a bucket handle motion. So the only way this works is if we can also somehow tie our inhalation to activation of an abdominal muscle. Let's say one that wraps all the way around our core, like the transverse abdominis. I like this picture. Look here. So you can see the transverse abdominis. That's that big abdominal muscle that basically wraps all the way kind of around the bottom of our soda can. It is the only abdominal muscle that inserts on the interior rib cage, so it's on the inside. And look at this relationship with the diaphragm. The transverse abdominis interdigitates with the diaphragm. This is so cool. So when we take a breath, these two muscles are actually physically intertwined, which allows the synchronization of pressures needed when the diaphragm is contracting to have it be met with the necessary abdominal wall support to maintain postural support. It is so cool. And the TA, if we put our soda can back up, some of you might have thought of this when I was mentioning that if we just close it at the top and the bottom, everything is great. But of course, we also need stability around the can. And the transverse abdominis wraps around the bottom of that can. And it's physically interwoven with the diaphragm so they can work in synchrony together to create the necessary abdominal wall support so that when the diaphragm descends, that force can be transmitted to the ribs to pull them up and away. And then, of course, just in the order of your notes, the pelvic floor is the inferior sling that's holding it all in from the bottom. Then, once your dome is stabilized, the coastal portion of the diaphragm, the part of your diaphragm that is attached to the upper margins of ribs 8 through 12, can elevate the ribs in what's called the pump handle motion. So this is a side view of the ribs, right? This is your vertebral bodies. And the pump handle motion allows you to pick the ribs up in an anterior and superior direction, much like the handle on the pump of a water pump. I don't even know if you guys have used these in your life. Maybe like hikers out there. I feel like in the trails in Wisconsin, they still have pump handle water fountains, but we'll have to get an app for this or something so people can appreciate pump handles anymore. Let's take a look at the movement of the rib cage with a little motion to make sure we can visualize what's happening here. This is a three-dimensional recreation of the diaphragm within the rib cage. And you can see at the lower levels of the ribs, as the diaphragm descends, there is this bucket handle motion where the ribs are going out and up. But this view is showing how the anterior segments are actually being pulled more in that pump handle motion, where the accessory muscles like scalenes attaching to first and second ribs and sternocleidomastoid attaching to the manubrium and the clavicle can actually pull on those attachments to move the rib cage in an anterior and upward direction. So hopefully you're relatively comfortable with the association between the diaphragm moving the rib cage. But let's add in this element of what role the diaphragm may play in spinal stability. Now, to be clear, contraction of the diaphragm cannot voluntarily move the trunk, but it absolutely plays a role in spinal stability because as you increase intra-abdominal pressure, you stabilize the spine. And the diaphragm has a key role in contributing to the generation of intra-abdominal pressure, as it's the ceiling, and as it comes down, it can increase that pressure. So we've already mentioned how having positive pressure in the abdominal cavity is actually used to help stabilize the central tendon of the diaphragm, giving it the ability to kind of do that bucket handle pushing out of the rib cage. But in the reverse, that positive pressure that aids in our breathing, that positive pressure also aids in the stability of the spine. And you all actually already know how to use your diaphragm for stability. If I put a heavy box, really heavy box in front of you and asked you to lift it up, what would you do? You'd hold your breath. You would hold your breath and bear down. And you would have a better chance of lifting that heavy box. Because by doing an inhalation and then bearing down with your diaphragm, you have created a stability around your spine. Now, why does that help you lift the box? Proximal stability increases distal strength. Our periphery is only as strong as the base to which it is anchored to. So if you can increase spinal stability, you can increase peripheral force production. And there are studies that show this relationship. In this particular study, they looked at the effect of intra-abdominal pressure on both hip and knee joint strength. And you can see in the highlighted sentence, the current results of this study suggest an increase in intra-abdominal pressure has a causal effect to specifically improve muscle strength. And in this study, it was of the hip extensor. So increasing proximal stability allows for a greater production of force distally if you can give your peripheral muscles a stronger base from which to pull from. This becomes a problem when, in order to be successful in an activity, in order to generate enough peripheral force to be successful in activity, you have to hold your breath and create this very rigid column of stability around your spine. And we see this all the time in patients who are weak and ineffective at generating peripheral force. They'll hold their breath. Obese patients are classic breath holders. The tasks often exceed their ability to stabilize, so they hold their breath and they create a rigid tube to try to augment their peripheral force generation. We will kind of explore this and play with this a little bit in lab. We'll talk about some of the pitfalls of breath holders, specifically if you're relying on breath holding for a functional activity and you have any compromise to oxygen saturations or your pulmonary system, it will be a really negative compensatory movement pattern. But also, eventually you have to take a breath. And when you release that breath hold, this is when patients can fall and they have a kind of a crumbling of whatever their force production was that was relying on this central column of stability. So we'll play with that and practice it. One thing I want to mention before I go on to the next slide, in your notes it talks about the pattern of muscle activation kind of right under point A in the stability section where it says diaphragm EMG activity precedes peripheral muscles by about 20 milliseconds independent of the phase of respiration. So we can effectively use our diaphragm for stability for peripheral muscle force generation independent of what phase of respiration you're in. You can do both simultaneously. You can be breathing and exploiting the benefits of the diaphragm for central stability. And we'll dive a little bit more into that in functional movement patterns in lab. Lastly, let's talk about intercostals. Obviously, we have internal and external intercostals, and their names kind of are the opposite of what it sounds like they do. Internal intercostals assist in exhalation, and then external intercostals assist in inhalation. So as you can see in your notes, the primary job of the intercostals is to stabilize the rib cage against that negative intrathoracic pressure. Basically, you prevent the intercostal space from being sucked in with every single breath. So if we add that to our story of the soda can, which is a flimsy outer container that only creates stability by being pressurized. And we said the top of that container is the vocal folds, the bottom is the pelvic floor, the pressure generator is the diaphragm. The abdominal wall is primarily stabilized by the transverse abdominis, and then the intercostals help to stabilize the thoracic cavity and prevent the negative thoracic pressure from sucking inward with every breath. When the intercostals fail to do that is when you see intercostal retractions, which you can see up at the top video here. And I'm just going to click over to a video so you can see this in real time. So with every breath, you can see that the intercostal space is getting sucked in, that the negative intrathoracic pressure is not being stabilized against by a functional intercostal unit, creating that subcostal retractions. So its primary job is stabilizing the rib cage. Its secondary job, as I mentioned at the beginning, it can assist with inspiration, the external intercostals. In the upper chest, the external intercostals can help create that anterior and superior expansion, kind of helping with the pump handle motion of the upper chest. We'll do breathing pattern assessments in lab, but when you look at someone's movement pattern, the upper chest has the least amount of lateral movement and the most of this bucket handle movement. So then when we get to the lower chest, there's more of that lateral and superior expansion. Its third job is that intercostals can assist in rotation. External intercostals create a contralateral rotation, whereas internal intercostals perform an ipsilateral rotation. So it will contribute to the overall functional movement of rotation. So this lecture has served as just an introductory jumping off point to a lot of the concepts that we're going to be weaving through the lab and then just concepts throughout the semester when we talk about treating patients. Because cardiopulm focuses a lot on the survive piece. We think about how there's impairments to the pulmonary system and how can we maximize our patients' chest mobility, respiratory muscle strength, posture to help facilitate basic breathing needs. Like how do we stop them from desaturating when they do certain things? This is talking about how we're using the cardiopulmonary system to survive. But I'm hoping throughout the semester to continue our thinking on how we can take our goals only from survival and into allowing our patients to thrive. So the muscles of respiration are obviously involved in breathing. And we will talk about many examples throughout the semester that they become impaired or they're inadequate for the impairments within the lungs and vice versa. But I'm hoping to also weave in this really key element of the role of the muscles of respiration in providing postural stability. Our diaphragm must be able to perform dual roles of both inhalation and stability. And you will see this time and time again with your patients. If there's ever a conflict between physiology and physical support, the diaphragm will always pick the physiology. It'll always choose maintaining breath at sometimes the expense of stability. We'll talk about this in different ways, but there's a number of studies that have shown this relationship where when you increase the demand of breathing, the role that the diaphragm can play in low back stability decreases. In this first article, they actually induced inspiratory muscle fatigue in control subjects. So individuals who did not have problems with breathing, they induced inspiratory muscle fatigue, and they showed that their postural control strategies were negatively impacted. They would use a rigid postural control strategy over a multi-segmental. So they developed a less dynamic and responsive postural control strategy as soon as the physiology of the pulmonary system was challenged and those muscles had to make a choice. Similarly, this second study showed that patients with low back pain were treated with inspiratory muscle training. They strengthened the muscles of inspiration to improve the strength and support to the respiratory system. And what they found was there was carryover, that the impact of increasing inspiratory muscle strength improved postural control and decreased low back pain in chronic low back pain sufferers. This study showed that patients with COPD demonstrated very similar postural control deficits as patients who have chronic low back pain and don't have a pulmonary disease. In fact, the greater their inspiratory muscle weakness, the greater their balance deficits. So cardiopulmonary rehabilitation isn't only about interventions to help individuals survive. It is starting to add the muscles of respiration into the movement patterns, postural control strategies, and stability that we need to thrive, as it says on the slide, and do higher level dynamic activities. There's research that shows ballerinas who are doing their pirouettes, when they hold their breath, they're more likely to fall out of their pirouette because they have this rigid stability control. When they have a controlled exhalation, they're using breath support to create the dynamic stability of this very high level functional activity. We talked about breath holders, people who rely on that rigid, stable core, and it creates too much stability. You need a breathing strategy that matches your functional needs. And we're going to see that over and over again in a wide range. And I really hope those of you that are super ortho driven can take pieces of this and add it to your patient practice at the highest level of function, that you're taking into account the central postural control mechanisms that your patients are using for stability and how they're using breath to support their function. One sort of funny example of this is the grunting that you can hear at high-level sports performances. And the best example is the tennis player that grunts on their serve. You get that big, loud noise during the explosion of their serve. And it's the use of breath support to enhance their muscular performance. And that grunting actually does serve a purpose. So studies have shown that when you allow a tennis player to grunt, you can increase the ball velocity of their serve. In fact, if we go to the conclusion of this study, the velocity, force, and peak muscle activity during tennis serves and forehand strokes are significantly enhanced when athletes are allowed to grunt. The combination of breath support and functional movement. So what's going on here? When you hold your breath holders, right? Holding your breath gives you maximal stability. But with max stability comes very little flexibility. So at the highest intra-abdominal pressure force generation, there's no movement. So if you can't move, if it's a rigid tube, it's going to hurt your ability to serve. So what do? You take a huge inhale when you toss the ball up for a serve. You hold your breath to generate maximal pressures. Then, right at the time when you need to actually do the physical rotation and forward flexion that allows the tennis racket to come down, you slightly open your glottis. This allows an eccentric release of your diaphragm. Now you have high pressure with movement. We're going to talk about this in the use of these patterns when you move sit to stand, when you're trying to get out of a hospital bed. Somebody can't do that technique. Can we use breath support? Can we use what we know about the soda can to enhance patients who can't get out of bed, to enhance our athletes and their ability to generate higher force velocities in their serve, in their strike, in their ability to have dynamic balance when they're dancers? We have to look at the central stability and the relationship between the pressure generator within our soda can and how it's allowing support with movement. And when does that relationship balance each other out and work together to allow the best movement possible? Thank you for your attention. We will practice these, see these over and over again, and I look forward to seeing you guys this week in lab. Take care. Bye-bye.